Good afternoon, everybody. I am Julie Kalkbrenner, a Lurie Children's Hospital Physician Liaison for the West and Far West suburbs. I want to thank you for joining us this afternoon as we introduce you to the Lurie Children's team for the Division of Orthopedic Surgery and Sports Medicine. For this session, we are introducing you to Dr. Laura Lemke. The Division of Orthopedic Surgery and Sports Medicine at Lurie Children's is nationally ranked by the U.S. News and World Report. We care for more than 30,000 children each year, providing a range of services for children with bone, joint, muscle, ligament, tendon, and nerve disorders, and offer the only pediatric bone health program in Illinois. This is how we are able to recruit the finest specialists in the nation, such as Dr. Lemke. Special programs within the Division of Orthopedic Surgery and Sports Medicine include the Concussion Program, which is uniquely qualified to evaluate, manage, and treat concussions in children and adolescents, as well as the Clubfoot Program, which is a comprehensive and multidisciplinary program for clubfoot, a congenital condition that can affect one or both feet in newborns. Dr. Lemke has been a part of the Chicago medical community for 2 decades, having received fellowship training at Lurie Children's in 2001 to 2002, and then in private practice in the western suburbs before joining the Lurie staff 5 years ago. Dr. Lemke's clinical interests include pediatric trauma, club feet, hip dysplasia, limb alignment concerns, and non-operative scoliosis, among other musculoskeletal pathologies. Dr. Lemke sees patients exclusively at Northwestern Medicine Del Nor Hospital in Geneva and performs surgeries at Northwestern Medicine Center DuPage Hospital in Winfield. Dr. Lemke is particularly passionate about creating strong relationships with patients and ensuring proper patient-physician communication. She is grateful for the opportunity to speak to all of you today. Before we begin the presentation, I just would like to let you all know that we do have a chat box running today within the platform, and please feel free to write any questions. We will have those addressed at the end of the program. Now I would like to introduce you to Dr. Lemke, and she is going to talk about the Clubfoot and Clubfoot program at Lurie Children's. So now, Dr. Lemke, I will make you a presenter.
Okay. I'm here. I'm having a little trouble with my, let's see. Let me try this again.
There we go.
How's that?
That's great.
Great. Okay. Well, thank you, Julie. I appreciate the introduction. I'm very grateful to be here today. Thank you all for attending. As Julie mentioned, I'm going to talk about clubfoot or congenital talipes equinovarus. This is something that a lot of providers at Lurie care for at a lot of locations, making it convenient for all of our referrals. And I'm just going to go through a little bit of the pathophysiology and the treatment of club feet, and I'm happy to take any questions at any time. So clubfoot is a deformity or a malpositioning of the foot in three planes. There is adductus of the forefoot, which is most obvious in the plantar view on the right side. There's varus of the hindfoot, which is the heel coming toward the midline, which you can see from both views. And then there's plantar flexion. The foot is pointed downward or in equinus through the tibio-talar joint. Clubfoot is the most commonly noticed deformity at birth that requires treatment. There are a few others that we're going to go through that don't require treatment. It occurs in 1 in 750 to 1,000 live births in the US, with a ratio of 2 to 3 to 1 for males to females, more common in males. And 40 to 50% of the time it's bilateral. The exact etiology of clubfeet is not understood. Some sources give slightly variable numbers, but approximately 50% of clubfeet are neuromuscular or syndromic, and 50% are inherited or idiopathic. It's likely a polygenic inheritance with environmental factors that affect penetrance and expression, affect severity, and therefore the outcomes with treatment. The genetics of clubfoot tell us that unaffected parents who've had one child with a clubfoot will have a 3 to 5% chance of having another child with a clubfoot. That's often a question that parents ask once they've had one child. And that 25% of individuals who are born with clubfoot do have a family history. While some twin studies give variable numbers, it's estimated that 32% of monozygotic twins have concordance, where only 3% of dizygotic twins have concordance. Some of the environmental risk factors are in utero smoke exposure, early amniocentesis, which might lead to tighter packaging, tighter in utero, or leakage of amniotic fluid. It is not thought that tighter conditions later in pregnancy are a risk factor. It's only when there's lack of space earlier in pregnancy. I think we have to understand a bit about the differential diagnosis in order to be sure that we're treating the right problem. The first deformity in the differential diagnosis is metatarsal ductus, which is a common positional deformity that resolves with treatment. If it's rigid or persists beyond 5 to 6 months, these patients can be referred and they can be treated with a casting technique. Some of these patients have been treated in the past with shoes with a hinge in the middle of them or wearing their shoes on the wrong feet. While these are possibilities, there aren't any scientific studies that demonstrate that these are successful methods to improve metatarsal ductus. Metatarsal ductus is identified by looking at the lateral border of the foot, the blue line in these slides. When it's curved, we know that there's adductus through the forefoot, but in metatarsal ductus, as opposed to the adductus that's a component of clubfoot, it is passively correctable. In terms of the descriptors, in a normal foot, the heel bisector, a line through the center of the heel, will go through the second web space between the second and third toe, as demonstrated on the far left. A severe metatarsal ductus, the heel bisector will go through the fourth web space, the slide on the far right. And in terms of identifying adductus or estimating it, we use that heel bisector angle as a descriptor. Postural clubfoot is also part of the differential diagnosis, and you might recognize that I've used the similar, in fact, I think this is the same slide as in the previous slide, or same photograph as in the previous slide. And that's because postural clubfoot is very difficult at times to differentiate from true clubfoot. While it is more supple, passively correctable in the newborn, the adductus is correctable to neutral. The heel can move out of varus and into valgus, and the ankle can plantar and dorsiflex. These things are possible in the postural clubfoot, but not in the more rigid clubfoot. And in a postural clubfoot will resolve spontaneously, but I think these patients are still referred because of their positioning, and I typically follow them until resolution. Which again occurs on its own within a few weeks. Another positioning that we see in newborn feet is the searching toe. When the foot is in motion, the tendon in the great toe, the abductor tendon in the great toe tends to be a little bit overreactive. This is a primitive reflex that resolves on its own without any intervention, but it does create the appearance of the adductus of the forefoot looking worse. But again, it resolves on its own and is not something that requires treatment. The most common positional deformity in newborn feet is calcaneal valgus. Calcaneal valgus is an excessively dorsiflexed and everted foot, so much so that the top of the foot might be stuck against the shin. It typically resolves on its own in 1 to 2 months without any treatment. If there is any tibial bowing or other deformity that persists beyond 5 to 6 months, these patients should be referred. But again, this typically resolves on its own. The most uncommon foot deformity we see in newborns is a congenital vertical talus. These have a rounded or rocker bottom foot. This is rare and often associated with neuromuscular conditions such as trisomy 18. In the picture, the green oval represents the talus in a more vertical position. This is rigid, and these patients are almost considered to be the opposite of clubfoot. The plantar flexion is very difficult. These patients are stuck in dorsiflexion, but it's not as supple as the calcaneal valgus that's much more common. In terms of the clubfoot pathomechanics, again, there are some positioning. There's some foot positioning that creates the posture that we see. The ankle or tibio-talar joint is in equinus or plantar flexion. The talus and the calcaneus have almost a parallel position, and the forefoot is flexed, causing cavus and adductus of the midfoot. The final point is that this is not a disease of just the foot. It's a disease of the entire lower leg. And so these patients are going to have a smaller calf and foot compared to the other side, if not bilateral. Here's another clinical picture of a clubfoot. This one is a great demonstration of the posterior and the medial creases that we see created by the plantar flexion and the adduction. The sketch demonstrates the adductus of the forefoot, the inversion of the calcaneus or the varus, and the plantar flexion at the ankle joint. Here's an overhead view of the position of the bones. The darker yellow elongated bone is the calcaneus. The rounder, only partially yellow bone, I don't have a pointer, I'm sorry, is the talus sitting on top of the calcaneus. And you can see that the orientation of the talus and the calcaneus is shifted in a clubfoot, with the calcaneus being in varus pointing toward the midline. The body of the talus is rotated outward, but the neck is pointing down and medial. And then the navicular and the forefoot are shifted medially with adduction and some supination of the foot, creating that posture where the plantar portion of the foot is pointing inward and sometimes even upward. When we clinically classify these patients, we look at the equinus through the ankle, the varus through the hind foot, the cavus through the midfoot, and the adductus in the forefoot. We assess their flexibility, we assess the depth and the correctability of the medial and the posterior creases. In older children who, believe it or not, walk on these malpositioned feet, there can be callus, which is a stigmata of decompensation. And then finally, we assess foot size and stiffness. The smaller and stiffer foot is typically the more severe clubfoot. Ultrasound diagnosis can be seen 12 weeks at the earliest. It usually becomes more prominent in the second trimester. The finding should persist despite movement, but because this can be caught and not determine if it's persisting despite movement, ultrasound diagnosis can be up to 40% false positives, which is great news for families, but something to be aware of when parents prepare for this and maybe don't have to go through clubfoot treatment. 3D ultrasound has not been of additional benefit in terms of diagnosing with more sensitivity, and we do use x-rays in older patients. The picture here is actually a 20-week ultrasound. So the goals of treatment are a pain-free strong foot with range of motion that is functional and as close to full compared to the other side, if not also a clubfoot, as close to full as possible. Those were the parameters under which Dr. Ponseti did his studies to demonstrate that his treatment was the best out there, and which has now become the standard of care. Dr. Ignacio Ponseti was an Italian pediatric orthopedic surgeon who practiced for his career in Iowa. He was 95 when he stopped seeing patients shortly before he passed away in 2009. I was fortunate enough to attend his seminar shortly after my fellowship at Lurie, and he really is an amazing teacher as well as a clinician, and takes great care of patients and families. His method calls for a well-molded above-knee cast with molding of the adductus and the varus portions of the deformity. And 90% of patients require an Achilles tenotomy to allow for the dorsiflexion required to create full motion. Working to stretch the Achilles with the cast can lead to a rocker bottom foot or stretching through the midfoot, and that's why the Achilles tenotomy is required. I tell families that while the casting seems like a hard part, it's the bracing that is the most challenging. Kids after 6 weeks of Ponseti casting, Achilles tenotomy, and another 2 to 3 weeks of casting after the tenotomy wear braces until the age of 4.5 or 5 years. So we start with casting. There's 5 or 6 casts changed weekly. In Dr. Ponseti's literature, I think he says change them every 5 to 10 days. We do weekly for ease of schedule. The first cast, or the cast that's on is removed. If it's the first cast, obviously nothing's removed. The foot is stretched to correct some of the adductus and the varus, and the cast is applied. Putting on a long leg cast with 90 degrees of knee flexion helps to prevent the cast from slipping off. It also helps control rotation. This is an example of a clubfoot correction and the casts applied. So you can see on the far left, this is the newborn with the adductus through the forefoot and varus in the heel, and the foot is plantar flexed. In the final slide on the far right, you can see that the foot is overcorrected. There is overcorrection into abduction, but that if you look closely, the foot is still plantar flexed, and that's why these children require a tenotomy. In every cast, well, in the last one, the angle isn't correct, but in every cast, you can see the toes, you can see that they're pink. Believe it or not, sometimes these kids still slip out of their casts. If they do, we can use adhesive on the skin to keep the cast padding from slipping. But the kids who slip out of their casts are often the more resistant ones, so they're a challenge to begin with. So after 6 weeks of casting, the Achilles tenotomy is performed. This is a minor procedure that I typically do in the operating room, sometimes with general anesthesia, sometimes not. Using general anesthesia aids in applying a well-molded cast because you don't have a squirming child, but it can be done under local. There are some rules about the concerns for postoperative apnea in a preterm baby, and so if parents don't want an overnight stay after an anesthesia, then we will use local if they've had a preterm child. So this is Dr. Rebecca Carl's slide, but it's really cool. The blade is inserted medially parallel to the tendon so that we can ensure that we're between the neurovascular bundle and the tendon, and then the blade is turned 90 degrees to transect the tendon. The track for the tendon is still there. This heals up in 2 to 3 weeks. So another post-op cast is applied in overcorrection into abduction, but with dorsiflexion this time. And this cast remains on for 2 to 3 weeks. Then the child is placed in the shoes and bar. The shoes used to be a bulky leather shoe that probably wasn't very comfortable. Now it's this nice molded plastic with this soft suede, and I think the kids do a lot better in them. The boots are above ankle boots so that the feet, so that the ankles are positioned in dorsiflexion at 10 degrees. The heels are at shoulder width and the feet are externally rotated. Dr. Ponsetti's method says 60 degrees of external rotation on each side. The kids wear the braces for 3 months full time, and this usually causes very minimal delays in gross motor function, nighttime and naps until 4 years old. I can tell you that the most successful kids in wearing their braces have been the ones that never take a break, the ones in whom it is their routine at all times. The kids who are allowed to take a break once a week, or don't wear it when they go to grandma's, or it's a slippery slope and they stop wearing their braces. Not wearing the brace directly correlates to recurrence. This is the child after 3 months of bracing. You can see that the thickness of the fat around the ankle looks a little different on the right clubfoot side with the blue arrow. That's perfectly normal. But this child has had a really good result. And if he continues to wear his braces, recurrence is very unlikely. Depending on how you define recurrence, there's maybe a third have mild recurrence. Before age 3, this can be easily corrected with 1 to 2 casts. And then going back to the bracing full time. Once they've worn their braces full time until the age of 4 or 5, the risk of recurrence dramatically decreases. 5 to 10% of these patients may need additional surgery with recurrence. That might be an Achilles tendon lengthening. When they're older, we cannot percutaneously release the tendon. We do need to make an open incision and lengthen the tendon. If there is residual forefoot adduction or supination, we transfer the anterior tibial tendon from the medial cuneiform out to the lateral cuneiform or the cuboid on the lateral border of the foot, so that dynamically the foot comes into abduction and more into pronation. 3% or less will require surgical treatment per clubfoot. This is usually performed sometime after the age of 6 months. In the long-term studies, before Dr. Ponsetti's treatment became the standard of care in the mid-90s, maybe late 90s, most kids had surgery between the age of 6 and 12 months. And unfortunately, 2/3 of them have developed fair or poor function by the age of 25, often because of overcorrection or undercorrection. So again, those kids who've been resistant to the Ponsetti technique are often neuromuscular syndromic. I mentioned those are the kids who can wiggle out of the Ponsetti casts. That's what makes them resistant. They go on to surgical correction at 6 months at the earliest. They require release posteriorly, medially. Sometimes they have toe flexors divided. Older children may have osteotomy, external fixation, or other fusion and salvage procedures. This talk was focused more on newborns, but just a little bit about other procedures. Historical incisions for club feet. In figure A is the Turco incision. That was the incision to create the release and correct the deformity unilaterally. The Cincinnati incision is a U-shaped incision around the back of the foot that allows access medially and laterally for correction. I guess I'm just old enough to have some familiarity with this with this incision, because some of the people I trained with were not using the Ponsetti technique in the mid-90s. So through this incision, we would release the soft tissues, realign the talus and the navicular, as well as the talus and the calcaneus, as demonstrated in the earlier slide with the bones, pin them in place and allow them to heal in the corrected position. But again, with growth, this led to over or under correction and not great results. The lower slide is an adult who was walking on the foot in this position. This is these patients are often seen in developing countries, and he was fixed with an external fixture. So in our care of newborns, I think that one of the most important things we can emphasize is the relationship with family. This is a very labor-intense treatment. It's 6 casts on a weekly basis, followed by a minor surgical procedure, 2 to 3 more weeks of casting, and brace treatment. I think it's important for patients to have convenient locations for regular appointments and easy communication with the office, like the direct back line when once they are an established patient. Sometimes I call referring offices and end up on multiple holds and transfers, and I know that's how things have to start, but I hope that our patients have a more direct line for communication with us as things move on. And I think that these kinds of things lead to a high success rate. I listed on this slide all the locations where Lurie providers see patients with club feet, and I see that the list I put in shortly before this talk auto-corrected New Lenox to New Lemke. I apologize for that, but that should say New Lenox out near Joliet. So our long-term expectations are that children with club feet who are treated with serial casting have an excellent outcome. They do have to understand that the affected calf or calves will be smaller. There will be a difference if they are unilateral, and it's been estimated that the foot will be on average be 1 centimeter smaller. With a note, Target will sell people 2 different size shoes, and so will Nordstrom. They will sell people 2 different size shoes. Those are my 2 resources for kids with different size feet. Just some of the classic studies that we can quote regarding the Ponseti method. One is obviously older than the other, but both demonstrate that Dr. Ponseti's method has a much better result, much higher percentage of good and excellent results as assessed by strength, motion, and lack of pain than any other method for the treatment of club feet. And then here are some 3 very recognizable athletes who were reported to have had club feet. I don't have any knowledge that they truly had the same treatment that I've mentioned here, but I put this slide in here because this is what people find on the internet, and I think it gives families an understanding that their child can still have a full functional athletic career after treatment with club feet. I just wanted to talk about a couple other things that I think are kind of neat with regard to taking care of kids with club feet. National Clubfoot Day was declared after Dr. Ponseti passed away on his birthday, June 3rd. The Ponseti International Society treats kids throughout the world for club feet, and does a lot of work to take care of the 80% of the 200,000 kids per year who are born with club feet. 80% are in developing countries, and Ponseti International has made a huge impact on those children's lives. So in summary, clubfoot is the most common congenital foot deformity that requires treatment. The current treatment, while time consuming, is minimally invasive and extremely successful. And the long-term outlook for these patients treated with the Ponseti method is excellent. Thank you.
Thank you, Dr. Lemke. That was great information. There are just a couple questions that I have because these first off, what happens if these are diagnosed? What's the earliest age, I guess, where you would like to start seeing these babies?
So most of these kids are referred right after birth, but as long as we're casting them in the first 6 weeks, 2 months, really the outcome is the same.
Okay, so between 6 weeks and 2 months. Now, since the overlap, with the intensive treatment, because the baby's so young, it also coincides with like the high number of visits that the primary care physician sees, during that time. Is there any extra support or anything you can recommend for the primary care to help the family with, just because they're seeing, the pediatricians will be seeing the patient so much, just as you will be, anything that the pediatrician can do to help support the process or the program?
No, I know one of the concerns is always that the baby's weights are questioned if they're weighed with the casts on. And although the same materials are used for every cast, that's one of the things that I've actually made sure that in the office, when that's a question, we weigh the casts so that the pediatricians have an accurate weight for the newborns. On the flip side of that, just helping the families understand that their kids can have a fully functional, normal, athletic life after being treated for their club feet is I think the greatest support you can give them.
Great. Okay, thank you very much. I don't see any other questions in the chat box, but I do want to give a special mention. We have several attendees today that have actually been attending all of our 5 webinars today to hear all about the Division of Orthopedics, Surgery, and Sports Medicine at Lurie Children. So I just want to thank you for your attention and interest in our programs. And also just want to thank everybody that joined in this afternoon for a 5 o'clock session. Hopefully you gained some great information. And thank you, Dr. Lemke, for your time. So we will be hosting another ENT day sometime in May, so stay tuned to your email boxes and we will be sharing more details in the future. But thank you, everybody, for joining us today. And one last point before I sign off here, the slide I have up right now, Dr. Lemke does have her contact, hopefully you can see that. Her contact information, her direct line, her cell phone, and email. She is on the Epic platforms for both Lurie and Northwestern Medicine, so you can feel free to send her an in-basket should you need. So thank you, everybody, for your attention today, and enjoy the rest of your evening.
Great. Thank you.